Attendees are in listen-only mode.
Hello, and welcome to our Pathways webinar. First, a quick guide on how to use the GoToWebinar. Please move any electronic handheld devices away from your computer and speakers. We suggest you close all file sharing applications and streaming music or video. Please check your settings in the audio panel if you're experiencing audio problems. During the presentation, you can send questions to the webinar organizer, but these will be held until the end. We will plan to save about 10 minutes to respond to questions before the end of the webinar. All audience members will be muted during the call. A recording of this webinar and a PDF of the presentation will be available tomorrow online at www.pathwaysrtc.pdx.edu. Our webinar is entitled Bridging Service Gaps, System Integration Strategies for Service Providers Working with Young Adults with Mental Health Issues. My name is Eileen Brennan, and I'm a research professor at the Pathways Research and Training Center at Portland State University. I'm standing in today for my colleague Pauline Givangi. I'll be the facilitator, and my co-presenters today will be Ryan Melton, Lucia Campbell, and Mark Fagan. I'd like to introduce our co-presenters. Ryan Melton is Clinical Director at the Early Assessment and Support Alliance, or EASA, Center for Excellence in Portland, Oregon. EASA provides early assessment and support for youth and young adults experiencing their first occurrence of psychotic symptoms and for their families. He is also a Senior Research Associate at the Regional Research Institute at Portland State University. Lucia Campbell is a young adult employed as an EASA peer support specialist. And Mark Fagan is Vice President of Clinical Operations and Youth Services at Thresholds, a multi-service youth organization with headquarters in Chicago, Illinois. Thresholds provides community supports and services to young adults with serious mental health conditions who are transitioning from foster care to justice settings. And next slide, please. At the end of this webinar, our objectives are for participants to understand the challenges and outcomes for young adults related to service fragmentation, discuss state-level and individual-level strategies for addressing service gaps, learn about strategies employed by organizations such as EASA and Thresholds to overcome service gaps, describe the process of service integration and of building bridges across systems and services. So, next slide, please. I'd like to begin with a brief discussion of the challenges related to service fragmentation and some strategies to bridge service gaps. Next slide, please. Youth and young adults with mental health conditions and their families and service providers experience many challenges related to service fragmentation. First, there are gaps in service continuity due to the separation between youth and adult serving systems and due to age-based eligibility policies that restrict access to services to young people above or below a specific age. Additionally, most states lack transition services, and systems are fragmented, and they have different eligibility criteria as well as different missions and goals. There are also differences in service provider training and identity, resulting in different emphasis and perspectives of services that are given. And then also, collaboration and coordination across services takes time, and there is a lack of incentives for this collaborative work. And finally, the primary service system that a young adult is connected with may shape his or her identity. The young person might have a personal identity as a service user, consumer, patient, or offender, resulting in difficulty perceiving other identities. Next slide, please. I'd like next to talk about outcomes for youth and young adults with mental health needs. While there are no identified causal links, service fragmentation may contribute to poor outcomes for young adults with mental health needs. For example, data from the National Longitudinal Transition Study, the NLTS2 study, and studies by Vanderstoep and Paddock have shown that youth and young adults with mental health needs complete high school at lower rates than youth with other disabilities, participate in post-secondary education and enter employment at lower rates than other young adults, have significantly higher rates of substance abuse, homelessness, and involvement with the criminal justice system than other people with disabilities, and have higher rates of unintended pregnancy than other youth and young adults. Excuse me. While other factors may contribute to these adverse outcomes, they're made worse by fragmented services. For example, young adults who engage in risky behaviors such as substance abuse or criminal activity may end up in justice settings that do not provide access to the mental health treatment they need to change patterns of risky behavior and to engage in secondary education, post-secondary education, or employment. Next slide, please. Next, let's look at state and program level strategies to address service gaps identified in a 2008 report of the GAO, that's the U.S. Government Accountability Office. This report examined the challenges facing young adults with serious mental illness and described 4 states' initiatives to coordinate services. The states involved were Connecticut, Maryland, Massachusetts, and Mississippi. According to the GAO report, these states improved access and coordination by integrating mental health treatment with employment and other supports. Specific system-level strategies include broadening eligibility criteria for mental health services to include young adults who do not meet all traditional criteria, coordinating referral, eligibility determination, and service delivery, developing formal referral processes across agencies and systems, using statewide and local interagency task forces to develop policies and identify resources, and leveraging federal and state funding resources, and involving young adults and families in developing policies and aligning supports. And then finally, the GAO report also identified strategies for service providers, including peer support providers, to assist young people to navigate service systems. These strategies suggested that as a service provider, you invite youth to identify goals across life domains and assist them to find settings that will provide opportunities to achieve their goals, and that you be familiar with available local, state, and federal supports, especially program requirements and eligibility rules. I'd like to recommend Moving On, which is a useful resource developed by the EASA Center for Mental Health Law. This resource analyzed 56 federal programs that fund services for young people with serious mental health conditions in the transition years. There's also a set of fact sheets to accompany this publication that was released a couple of years ago. This publication is listed in the set of resources that will be posted in the Pathways website after this webinar. As a service provider, you should also develop relationships with providers and agencies you refer youth to so that you can understand each other's roles and approaches, and you can be confident that young people will be treated with respect. And cultivate relationships with culturally specific and culturally responsive agencies so that young adults' cultural preferences will be addressed. Collaborate with providers and other systems to develop shared goals and coordinated plans. And if youth wish, accompany them to visit new agencies and meet new providers. And finally, coach youth in skills to advocate on their own behalf in reaching out to new providers, teachers, or employers. So at this time, I'd like to introduce Brian Melton, the Clinical Director at the EASA Center for Excellence and a Senior Research Associate at Portland State University Regional Research Institute. Ryan is going to talk about how EASA connects youth, young adults, and families to the services and supports that they need.
Okay, thank you, Eileen. I appreciate that introduction. As Eileen mentioned, today I'll be talking specifically about the EASA program, or the Early Assessment and Support Alliance, and then even more specifically how EASA addresses some of the gaps that Eileen referred to. I want to do a brief introduction to what EASA is specifically. As Eileen mentioned, it is a statewide program in Oregon that attempts to identify adolescents and young adults in the earliest possible stages of major mental illnesses, specifically schizophrenia-related illnesses and bipolar-related illnesses. So that's our primary focus. We identify both individuals try to identify individuals prior to the onset of those disorders, as well as just after those disorders. Then we provide 2 years of pretty intensive services to these adolescents and young adults. And we hope that by, at least our philosophy in providing some of these services, bridges some of the gaps that Eileen addressed. And I'll talk more about that in future slides. If you want to learn more about EASA, I strongly encourage you to check out our website at easacommunity.org and to follow us on our social networking outlets such as Facebook, Twitter, and Tumblr. One gap we're trying to bridge is to increase our presence on a social networking outlet so we can reach out to primarily adolescents and young adults about our services. So again, please follow us on these sites. I think we're currently around 750 likes on Facebook. Our goal really is to hit 1,000 by the end of the year, so I'm hoping to get a few more out of this presentation. Next slide, please. And go ahead and scroll through. Sorry about that. I think it's important to talk about our mission and then ultimately how that mission helps bridge some of these gaps. I mean, our mission really is to keep young people with the early signs of psychosis on their normal life paths and to not kind of direct their identities towards a mental health system or having an identity as a mental health patient. How we do this, or how we attempt to do this, is by building community awareness. How do we build community awareness? As part of our practice, we ask all of our clinicians in EASA to set a time aside specifically to do community education about the services. I mean, early intervention and prevention really only works if people are aware of us. So a good portion of their job has to be set aside to do community awareness and education. Once individuals are identified, we offer easily accessible, effective treatment and support. And I'll give you some examples of easily accessible. Some easily accessible would mean that anybody can call us. It could be a family member will call us. It could be the individual themselves. It could be a church member. It could be a coach. It could be a teacher. Anybody can call us, and we'll reach out to the specific person who's calling us and provide them with psychoeducation, support, and then try to find the easiest way to engage with the individual. And we'll do this even if the individual isn't quite ready for treatment. We've really focused on spending some time early to get to know the individual, to understand their strengths, to understand their community, even before they engage in treatment, which is much different than kind of how people generally enroll in mental health services. Again, we also hope by doing community ed and doing the work that we end up with a network of very educated community members. So that would look like that the community is aware of EASA, that when a member of the community sees what looks like the early signs of psychosis, they're calling us immediately. So that's, again, why community education is so important, because delays in treatment are one of those gaps that we're trying to fill. Again, the best way to fill that gap is if people are referring as early as possible. We also want our participants, the EASA clients, to be completely educated, and we actually want them to educate us. So another gap that we're filling, and that gap being kind of the cultural understanding of adolescents and young adults, is that integrated into our treatment is that we seek feedback all the time. We seek feedback at the clinical level by using feedback-based tools after sessions with clinicians, as well as encouraging our young adults as well as our family members to engage in focus groups around EASA or to join quality assurance committees. And we've specifically written that into our practice guidelines as something that needs to be done to meet the kind of fidelity of EASA. Then, of course, having highly skilled clinicians that are specifically trained in working with young adults with these kind of psychotic illnesses. And we train our clinicians on most current evidence-based practices However, we adapt those current evidence-based practices for adolescents and young adult cultures. I think it's important to note that some of the standards evidence-based practices that you all may be familiar with as clinicians and administrators, such as the IPS-supported employment, or illness management recovery, or multifamily group psychoeducation, were all became evidence-based by research on adults. So I think it's important that we seek feedback from our participants to adapt those evidence-based practices to a adolescent and young adult culture. Next slide, please. So I want to talk a little bit about EASA's evolution. We started in 2001 in 5 counties, and those 5 counties in Oregon. And those 5 counties are pink or salmon color on this a particular map. And that was in 2001. By 2008, we had received some legislative appropriation to expand our services in Oregon, and those are designated by the blue sites you see on the map. 2010, 3 other sites came on board without legislative funding, but just wanted to try to do the work, and we're quite successful at doing so. And then you'll note all the stars around the state. That's our 2014 expansion that basically is going to cover almost all of Oregon. So almost every county in Oregon will have access to an EASA program. Next slide, please. I think probably one of the best ways to sort of learn about EASA is to try to understand it from the young adult participants' voice themselves. So I'm going to take this moment to introduce Lucia Campbell, who will speak for the young adults in EASA. She's currently an EASA peer support specialist in our largest county in Oregon, in Multnomah County. And Multnomah County contains Portland, for those of you who are familiar with the geographical region. So welcome, Felicia.
Hi, everyone. Thank you for taking time to be a part of the webinar. So I'm just going to talk a little bit about how Multnomah County specifically, as an example, has helped to bridge some of the gaps in services when it comes to mental health treatment. In our particular county, we have been blessed with the resources to provide occupational therapy, obviously peer support services, which I'll go a little bit more in depth about because I'm biased and it's awesome. We are also where we offer multifamily groups, so part of bridging that gap is connecting clients with families and making sure that our continuum of services really reaches all the way around and you know, creates a connection and an education for the entire family and not just the client that's being seen by a clinician. And like Ryan mentioned, we are constantly building awareness through those groups. We are doing community outreach on a consistent basis through all kinds of ways. For example, I'm a co-facilitator of a group called MEAC, which is the Metro EASA Advisory Council, and MEAC is a group of local providers and all tri-county, and we come together once a month. And one thing, you know, for example, working on right now is community education, where we're looking at fidelity from last year and seeing, you know, past, present, future, what is EASA doing to continue those services, to build awareness of those gaps, and just really working hard to identify where they are. We've done things like we're working with the local Portland Police Bureau and getting young adults involved, and you know, for example, we've created videos with the local police where young adults and their families have acted out situations in which a young adult may be involved with a police officer, and they've given very awesome examples of how they would want to be interacted with. So we're doing that kind of community outreach and really getting young adults involved. So we do a lot to bridge those gaps, and you know, I'm going to give you a quick summary of peer support. That it's a definition that was adapted from W. Wyatt from the Peer-Based Addiction Recovery Support, History, Theory, Practice, and Scientific Evaluation. So just briefly, peer support is the process of giving and receiving non-clinical assistance to achieve long-term recovery from severe psychiatric, traumatic, or addiction challenges. This support is provided by peer supporters, people who have lived experience and have been trained to assist others in initiating and maintaining long-term recovery and enhancing the quality of life for individuals and their families. Peer support services are inherently designed, developed, delivered, and evaluated and supervised by peers in long-term recovery. So with that, I choose to bridge some of these gaps with linguistics. So, you know, in this definition, they use the term lived experience. So when I'm meeting with someone for the first time, I'm introducing myself as someone who has lived experience with mental illness and mental health challenges. I don't introduce myself as saying I'm someone who has a mental illness. I'm saying I'm someone who has had the experience. And being able to share that with someone is truly remarkable, and to the point where I've had clients approach me at my time in EASA and say that peer support services has been one of the most effective treatments that they've received while in the program. So it's pretty special. You know, I think teaching young adults and youth how to advocate for themselves is a huge part of bridging the gaps to services, especially while in hospitals. I find that going to hospitals while people are there, and you know, when folks are there, they're often just, even when they're there for the first time, they're slapped with a lifelong diagnosis and thrown into institutions for the rest of their life. And this is an opportunity to interrupt that situation and say, no, you know, EASA is a 2-year program, and it gives time for that person to really be evaluated and not get stuck with this label for the rest of their life that might interfere with any other type of care that they may receive in the future. So, you know, it's a chance to show people how to advocate for themselves, you know, whether it's, you know, using the words lived experience, showing them how to use those words, or how to advocate for themselves in front of doctors they've never met. It's a really unique perspective on challenging those service fragmentations. So with that, I think I'd like to hand it back over to Ryan, because he's got a bit more information on the specific services, and just wanted to thank you for having me. So I'll hand the torch back over to Ryan.
Thank you, Felicia. Yeah, so why is EASA needed? Because one, we do believe that there are significant barriers and gaps specific for this young adult population developing or in the early stages of mental illness. Here's kind of a cycle showing kind of the current entry into the mental health system for people who are maybe even new or even experienced long-term mental illness. One, sometimes if someone doesn't willingly have insight into the benefit of treatment, they don't necessarily enter treatment. And we know from our state's data that the largest gap in this area is adolescents and young adults. So the only way that they're kind of getting into a treatment system, if they're not willing to, is by meeting this dangerousness criteria, which you are all familiar with, that an individual to receive help against their will, for lack of a better word, is they must be dangerous to themselves or others. And that's really the only way to get in. I mean, it's not, it was very frustrating when I was a crisis worker many moons ago, and a family member would call up and describe a young person who was acting quite bizarrely and engaging in some behaviors that were starting to lead to dangerousness, but they weren't quite dangerous yet. And I had to tell them, gee, when they get dangerous, go ahead and call me back. Can you go back to the last slide, please? EASA tries to bridge that gap, so when we do get these calls, that we don't give a family member a message that the individual needs to be dangerous to receive services. We'll provide support to the family, we'll provide education to the family, or any support network person that may be calling on behalf of someone that they care about. So we'll reach out to them, and we'll even try to engage the young person, even when they're unwilling at the point, or maybe I don't want to use the word unwilling, that the condition has limited their kind of insight for that treatment could be helpful. So we'll engage, and we've added flexibility in our treatment model where we can spend as much time as we need engaging the individual before they essentially sign up for treatment. So in that, we're trying to move our focus away from pathology and the negative messages that come with mental illness, and really even away from that early medical model language, and focus more on what you're experiencing may be temporary, or what with the family. I explain that also to the family, and really focusing more on hope, and even identifying our program as an educational and vocational program more so than a mental health program. And we do this to try to limit those delays to care, and oftentimes when someone does get into care, it's inadequate care based on that it's not culturally sensitive to the needs of young adults and adolescents. And because people have kind of either delays to care, or they find the care inadequate, it can meet the needs of adolescents and young adults, people tend to become more acute, and that leads to disability. And when I say disability, I'm focusing more on getting into the SSI system. That ultimately leads to poverty and isolation. Again, the goal of EASA is really to break that gap at the earliest kind of possible stage, and engaging families and participants even when they're not quite ready for treatment. Other ways that we do this is that we can accept all forms of insurance. We're not just a Medicaid system. You don't have to be on SSI to receive services from us. And if we did that, we wouldn't really be a prevention system, would we? We would be missing 1/3 to 2/3 of our population if we only focused on the Medicaid system. Given that we're a statewide system, and given that young adults and adolescents move frequently, our system has agreed that regardless of what county you live in, as long as you're in EASA County, that other county will pick you up without having to go through the eligibility and requirements again. So if one EASA person moves from one EASA county to another EASA county, they'll be picked up immediately. Our clinical teams also serve both adolescents and young adults. There is no adolescent system, or there's no adult system and child system. It's just an EASA system. So that what the individual experiences is no change in system when they turn potentially 18. This is incredibly important given that the age range that we work with is that age range in which conditions like schizophrenia tend to hit. Yeah, I think I've talked a lot about that, and I'm getting low on time, so next slide. So here's kind of what the message is that we'd like to portray. One, that as people enter EASA, they're hopefully entering at a stage prior to the illness getting really bad, but even if it is at a point of acuity, we're still going to be welcoming, proactive, and hopeful that we'll engage with the individual in a place that they feel comfortable. We'll engage in their homes. We'll engage in a restaurant. We'll bring the whole team if we have to. Even our prescribers will travel to locations out of the office if that need arises. And again, our messaging, I think, is key. That we're not messaging this as a illness that's going to be with you for long term. We're messaging this as something that occurred that probably wasn't your fault, but it's something that you have control over, and we can help you through that. And given our wide range of services, everything from supported education, supported employment, peer support, occupational therapy, there's usually something that we can engage the person in that kind of meets their individual goals. Yeah, go ahead and go to the next slide. What we know about kind of the implementation of evidence-based practices and to keep a service like this going is that it doesn't work when mental health systems or clinicians just attend a webinar or just attend a training. that in order for a program like this to continue, it needs ongoing support, supervision, and consultation. So that's really our job at the PSU EASA Center for Excellence. We engage in kind of research around our outcomes. We engage in ongoing consultation with all of the EASA staff around the state. We provide ongoing training and really ongoing learning by continuing to seek feedback from our participants. And so really the goal of the EASA Center for Excellence is to continue that work of the EASA model on an ongoing basis, which is that rapid, quick identification with proactive outreach, continuing to integrate the voice of the individual in their support system, basing our services on our current evidence-based knowledge, but integrating feedback from our young participants, then ultimately supporting them out of the mental health system and not sending that message that they'll be anchored there for life. That is my time, so thank you very much. And so right now I'd like to introduce Mark Fagan, who is the Vice President of Clinical Operations at Youth Services at Thresholds in Illinois.
Okay, thanks, Ryan. Hope you all enjoyed hearing a little bit about EASA. It's making me want to go out and visit there. So hopefully you all got some interested thoughts from that too. And then please feel free to connect any questions in the chat boxes there. I think there's some people that have already submitted questions and things like that. And please feel free to keep them coming. We'll plan to have time at the end to address those. Okay, so as you see up there, I oversee the youth and young adult services at Thresholds. Thresholds is a large mental health agency, actually the largest in Illinois, and we provide services to sort of the whole age group, but really have a huge focus on adults. And out of that years and years and years ago, we sort of realized that we needed to do something separate and different for the emerging adult crowd. And so our youth programs are sort of born out of that. And the majority of our youth programs are focused on that emerging adult age range of 16 to 26 years old. The majority of our programs also are sort of based out of the child welfare arena. So it's sort of a different kind of young person than those that you might see at EASA or other programs similar to that. The majority of our young people sort of are within the age range of 18 to 21 and are often still attached to the child welfare system. As a result, they've had multiple placements in their lives, lots of out-of-home placements, lots of instances of suffering abuse and neglect early on in their lives, early experiences that have sort of manifested in complex trauma later on in life, lots of hospitalizations, running episodes, aggression, things like that, that have sort of gone on for a long time in their lives. Most of them have co-occurring learning disorders, relatively low IQs. We have a lot of young people that have sort of third grade reading levels and sometimes lower. And so we're working with young people that have sort of dealt with issues sort of all their lives rather than those young people that are just sort of now experiencing a break with mental illness. The majority of our young people we sort of work with those that have some of the highest levels of mental illness across the state that need sort of a placement and supports. And so our residential services are not like your typical residential. We're not out, in the country on a campus and things like that. Our residential sort of looks like 3 flats in the middle of Chicago, sort of scattered in different areas where young people will live there and travel back and forth in the community using public transportation and things along those lines. We're very community-based, so we live amongst our neighbors and amongst our community, our employers in the community and things like that, and integrate with them on a daily basis. And so the residential aspect is a place for them to live, but it's very unlike what you would see in residential programs across child welfare arenas and other areas. So again, we're mostly 18 to 21 for a lot of our programs, even though it extends both younger and older. We have a number of transitional living programs too, where young people live in some of their own apartments, and we'll talk about that in just a little bit. Parenting programs for young people for young moms that are that now also have their own children, and helping them both work within the context of their own mental health needs as well as the attachment with their child and moving on to their adult life as well. Again, we are very much involved in sort of the community-based aspect rather than sort of closed off to the community. So a lot of our programs are sort of programs without walls in that regard as well. We are founded in the TIP principles, and for many of you, you might know what TIP is. The TIP is a transition to independence process, and so that's sort of our foundational approach of working with the young adults, the emerging adults in our programs. And what that really means is that we're very big on early engagement and spending a lot of time around engagement, also around finding the best balance of allowing young people to experience things in their community learning and have a lot of experiential learning. And sometimes the choices are going to be great and we're going to be there to help celebrate that. Other times the choices aren't so great and we are there to help them sort of learn it. So kind of vacillating between allowing young people to take more and more ownership over their lives while also providing a huge safety net for them to learn from some of those experiences. The final thing is that our job is really a bridge to adulthood. And so as we're talking during this webinar about making connections, I'm going to sort of illustrate not just what we do in young adult program, but really sort of lessons that hopefully some of these things you can take with you that will work in some of your environments, or you can think about tweaking to work in some of your environments. And for us, it's really about kind of taking young people that have been involved in a child-serving system for a very long period of their lives to then kind of preparing them for not just what an adult system might look like, but really for what adult living might feel like for them as they're moving forward. Okay, we can go to the next slide. So if you click through here, what you're seeing here is just a real quick snapshot, if you don't mind returning really quickly, is just a real quick snapshot of the young people and the diagnoses. So what you'll see is that our primary diagnosis is bipolar NOS with schizophrenia as a second. What's really interesting, though, and I think really salient, is the secondary diagnoses of PTSD as a majority for our young people. And we did a study just recently where we found that 97% of our young people meet criteria that would fit within the PTSD category. And so a lot of our young people have really experienced some pretty significant trauma early in their lives. Okay, we can go to the next slide. So that's sort of the platform of what I want to talk about here, is sort of bridging the cliff. And there are many examples of creating service bridges and bridging that cliff, and Ryan and Felicia were both able to discuss some of those a little bit. And I'm going to kind of expand on that as well. And I sort of divided them into some of these subcategories. And there's lots of examples across the country as well as in Illinois and within thresholds. These are just a few examples that hopefully you can take an advantage of. And the idea is that, you know, emerging adults represent a population that have the highest level of mental health needs, yet they're the least likely to engage in services. So a lot of times we may be concerned around, you know, whether there's enough services and in enough areas that we're trying to work in, and then also concerned about the right services and supports. But the thing that we tend to miss out on sometimes is, even if you have both of those two categories, sometimes we're missing out on, you know, are those services and supports ones that emerging adults really want to take advantage of? And so they need to be appealing and interesting supports and relevant supports for them in a lot of ways. And hopefully we're going to point out some of those areas. So when we talk about education, a couple quick points here is we want to think about, for those that are still connected to high school, the concept of academics and transitions, and that two great tastes taste great together. Having young people that that are still within the high school situation, having the opportunity to take advantage of transition goals and building transition goals into IEPs when students have IEPs, and looking at that in Illinois, and I know in a number of other states, that young people can refuse their diploma while still working on their transition goals. And so those transition goals can consist of working to find an apartment, or connecting with job experience, or, you know, starting post-secondary classes while they're still in high school. And so as long as that's written into their IEP, they don't have to accept a diploma and thereby lose the services and supports that they can get from their high school, while those transition goals are still being worked on. So that's one piece. The other thing is really working closely with departments in schools to make curriculums relevant, especially for young people that might be in and out of school quite a bit. That experiences through learning and applying that curriculum to real life situations are important. So if you have a young person that is really interested in the medical field, what would that look like? How could they do a visit that's associated with that? How could in the English that they're doing have some reading that's involving the medical field or mystery that's involving those sorts of things? And especially for young adults and especially those that have higher levels of mental health needs, making those pieces of the curriculum very relevant has been really important to our young people, and they tell us that all the time. It helps to build executive functioning and abstract thinking, and this is one of those times where building those capacities is more important than any other time in their life. Another piece of the education is approaching community colleges and seeing if there are opportunities for students to take classes while still in high school and getting the supports through the high school. And then finally, service learning as a part of curriculum is really important as well. And our young people tell us all the time that they want venues to be able to give back and to be able to provide support for early emerging adults that are just now sort of starting to experience what life is like. So let's talk a little bit about employment. Ryan had mentioned the IPS model, and we rely pretty heavily on the IPS model, but what we noticed is that even though there is a lot of evidence base for adults, it's similar to what Ryan said, is that in some ways it wasn't really working for young adults as it stood. And so we're going to talk a little bit about the adaptations in a little bit, but what we do find that gels really well for emerging adults is sort of the place and train concept. The idea behind this is that we're focusing on competitive employment in the community, so we're not having young people do a lot of early workshops and house sorts of activities. That's really around getting jobs in the community that they're interested in figuring out. And so that leads to the emerging adult choice. The idea that everyone can work regardless of what level of mental health needs you have and regardless of what kind of obstacles they're working with, that we see young people in the work world as building that social capital. And then kind of gluing together the employment and the support that goes with that. And that what we know is that, work is not sort of a means to an end after having mental health issues. Work is part of young people getting through their mental health issues. And it's not just a level of getting past your symptoms, but it's also about part of that recovery process. And so we see those two things working together. A couple other quick things on here is that one of the more important things that we find is the integration of employment services within the concept of other mental health services. And so having the opportunity for, an employment support staff to be able to communicate with a mental health staff to say, okay, we're going to be applying for this job, which, right now he's feeling a little stressed about that. So for the therapist, can you make sure to spend some time talking to him about this or that? Or, you may have one person that you may have a team come together and talk with the young person and make some decisions about who might be a good person to help remind them of their coping mechanisms after they're leaving the job site, things along those lines. So those individual supports are really important, and building job connections in the community is really great. So, one of the connecting pieces is really figuring out what the young people you're working with are interested in doing for work, and then that's where you do your job development and create connections in the community. So let's go to the next slide. So talking about employment and education, one of the things that we had the opportunity to do was create a feasibility study in conjunction with the University of Massachusetts and with Dartmouth to look at what adaptations do we need to make to the IPS model. And so one of which was knowing that young people are often, very differently than adults, are vacillating between employment endeavors and education endeavors. We needed to make sure that we had a good focus on both of those pieces, and that supported employment and supported education had to be connected. And so we matched those kind of two things up, and we also noticed that a number of the other adjustments we had to look at is allowing for things like internships and short-term job opportunities that For a lot of our young adults, they haven't had a lot of work experience. And so right now, they may take jobs and quit jobs, or they may take jobs and get fired from jobs. And we have to allow for those experiences and put emphasis on those job starts rather than emphasis on the real long tenure. So that's another part too. Another adjustment was thinking about is just thinking about other ways that young people get involved in jobs. Is sometimes internships start you off in those sorts of endeavors, and they may lead to full jobs. And so kind of taking stock in that as well. The third major adaptation we made to this was knowing that young people want to connect with other young people about their lives and things like that. And so we really embedded a peer mentorship model involved, and Felicia had already kind of talked a lot about that, but having peers be able to talk about their messages and what's important in terms of going down endeavors with employment and education was really powerful as we move forward. Okay, let's go to the next slide. So a couple things in terms of family relationships, and what we know is that we need to work on allowing emerging adults to create their own definition of family and who they consider family, and that there oftentimes is a renegotiation of the involvement of family. What that means is that, as young people start to get to legal age where they're making decisions for themselves, we have to kind of think about how to, even before that, start to build some of that empowerment over their trajectory and help them build that early support and help them kind of think about, now that they are getting to be an adult, how might that relationship change with mom? Or are there other people that you might rely upon for financial support, yet they may be very different than the folks that, the people in your life that you can rely upon for emotional support? And so thinking about how that makes sense. And what we also know is that having trusted adults in a young person's life often can be the game changer in terms of ongoing success in young adulthood for those with higher levels of mental illness. And so we really want to help young people start to develop those relationships and think about how they're developing that in more of an adult sustaining way. And oftentimes now is the best place for us as service providers to think about how to help them work through those purposeful relationship building activities. So the next concept here is one that we use in Illinois, and so I can't take credit for this. This is something that works out of the child welfare arena. But this is a way that we sort of connect the child-serving world to the adult-serving world. And it's this concept of launch. And so the idea is that, we start thinking about the transition into adult service provision for those that are interested and eligible about, a long time, and usually as they start to even get into our program. But at least a year out, we start thinking about specifically where they want to live and what services might be necessary. And then within 6 months, we have young people that are actually living in sort of their new kind of housing location while getting services on the youth side, and at the same time starting to get intakes and engagement from services on the adult side. So even though we don't have a lot of services in Illinois that really bridge that gap through the area, this is sort of the second best approach where we are able to blend some of our funding through some of the Medicaid rules, where we have service provision taking place on the youth side and on the adult side for a number of months for young people as they start to transition into those final adult services. The other thing is really around connecting to benefits early, figuring out where you can get benefits in terms of housing, in terms of other kinds of funding in multiple different areas. It can be difficult, but the more that you can educate yourself on understanding that and having young people understand what that would be like for them is really important. Okay, let's move on to the next one. So the next one that we'll talk just a little bit about is housing. And some of the ways of bridging the gaps here, has to do with understanding where you might be able to get housing plus services and where benefits might come into that. But the other part of it that really has been successful in a number of different arenas is looking into transitional living options. And so that doesn't necessarily mean building housing for 15 young people all in one building. And our young people tell us this all the time, that they want to have space where they can live with others in the community. And yes, they also want to be able to connect with other emerging adults that are similar to them. So how can you find that balance in between those two worlds? So transitional living options that oftentimes that are successful will look like maybe a 50-unit building or even a 12-unit building or something like that, where you have maybe 5 or 6 young people that live there amongst others in the community, and they have to live within the context of the landlord's rules and things like that. But then oftentimes you may have an apartment that's rented specifically for a staff member, and so that staff person is there to help support them with their goals, kind of help them with social, emotional activities, and also create gathering activities for the young people that are there, as well as a place to sort of check in when young people are experiencing crises and things like that. So the transitional living option is one that's really good, and so aggregated housing, having that in different areas is much better than having a whole bunch of young people all living together in one area. The other thing that can often go along with that is sort of continuum of payment opportunities, and so that might look like having young people slowly take more and more ownership over payment and more ownership over communications with the landlords and things like that. Okay, so let's go to the last one because I want to make sure we have enough time for a couple points here, and then we'll open it to questions. So there's a lot to say actually in all these categories, but especially here too, so I'll try to really just narrow it down. And we really want to think about kind of for wellness activities and really thinking about well-being for young people. And that can include things like housing and education, employment, and so forth. But it also includes the idea of brain-based and emotional connection, and really that connection between the mind and the body. And physical and mental health is more and more moving in this direction, both with ideas of care coordination, having, let's say, the psychiatrist making sure that they're communicating with a therapist who also communicates with the employment specialist and is driven by the young person and maybe a family member to try to work some of those things out. And that's what's really kind of moving some of these things forward. Brain-based activities of sort of centering, soothing activities, all of those sorts of things can affect the opportunity for young people to stay in their housing, to engage in education activities and things like that. The other thing that we know about emerging adults, and they tell us this all the time, is that often they don't identify with the concept of recovery from mental illness. That for them, a lot of times it's about the idea of discovery. And they're just now in a position where they're able to kind of think abstractly and discover what it is that works for them in a job site, or what does their diagnosis really mean for them, if anything. What does their relationship with their friends really look like, and who are the people that they can trust in their lives? So just discovering all these things, and we are the best venue for them to be able to do some of those things if we provide the right supports. I'm going to skip a little about Medicaid expansion, but the idea is that it's really increasing eligibility for those in the emerging adult arena. And then one of the other things that we do is we do have a program at Thresholds called Emerge, which is just really fantastic. And it's a total team approach similar to what some of you guys might know as an ACT team that works for 18 to 26-year-olds. And it allows for young people to be able to connect it through those transition years using young adult models, but it is sort of settled in sort of an adult financing activity. And so kind of bridging the gap between those child-serving arenas and adult-serving arenas are important. And so, overall, all these things are just sort of about adjusting and changing adult best practices and kid best practices to really work for emerging adults. And so I think at this point we're going to pass that on over and take some questions.
Okay. I hope at this point I'm unmuted and can start asking questions. Can you hear me, Mark and Felicia and Ryan?
Yep.
Okay,
Yes.
great. All right. We've had questions from Michelle and Lauren, who want to get your advice about engaging families in a productive way. There was a question that indicated that sometimes families don't feel heard when decisions such as discharge are put forward. And another question about it's very hard to engage families, involve them in treatment processes. Do any of you have suggestions?
This is Mark. I can start. You know, there's a lot there, and I'll try to keep it somewhat short, and I can always talk offline a little bit more about that. But there is a big struggle, and especially, you know, for our population where they've been separated from family for a very long period of time. Oftentimes, it's hard to re-engage with some of those family members, and even for those in our population that have families, a lot of times the families have suffered a lot of their own vicarious trauma, and you know, oftentimes they may take the stance of feeling like they need a break and they need to move on and they need to have the young person sort of move in that area. But then you have other families that really are trying to engage and trying to figure out the best ways to do that, and there's different approaches for all those areas. Some of the main things that we do is really kind of work on both helping the families address their own trauma and their own changes as they're sort of trying to work through you know, the trajectory of a young person with mental health needs, and trying to address what that might be like for them, providing some both support and psychoeducation outside of just support for the young person. In terms of having them involved, there's a lot of things there, but one of the main things that we do is really work hard early on with the young person and helping the young person understand how important it is that even if, you know, there's some separation issues going on there, how important it is to have them somehow involved in their lives, and even though you're going to go through your trials and tribulations, what that might be like. So we often are working out those kinks over and over again and going through all the different motions of that, but helping the young person really sort of stay engaged and think about how their family can add to you know, the decision-making processes, and that even though we're always talking about independence, it really is more about interdependence and how to rely on other people in that arena.
Yeah,
I'd
just
also like to add to that, if that's okay. EASA offers a few times a year a family education workshop, and that really seems to get people engaged because we offer a Q&A with our on-site psychiatrists. You know, they learn about all the different parts of our program, and it kind of seems like after we do that workshop, a lot of eyes light up and people start to get really interested and they want to attend our groups and things like that. But another component I think that really helps families get connected and stay engaged is that, you know, our program, we're able, like Ryan kind of mentioned, like we're able to meet them at their homes, to meet them on their level, and to really help family members meet their needs, you know, whether it's helping out with rides or helping the client learn how to grocery shop on their own to kind of take some responsibilities off of their caretaker. And then another component that just came to my head is, you know, seeing a peer support specialist doing outreach and really trying to re-engage with their loved one is helpful because they're seeing, you know, in my case, a young adult who is very productive, who's been working for 8 years, and I think it gives them a little hope, you know, to see someone who has not been slapped with a diagnosis of SSI for the rest of their life, and so that's my piece.
And Ryan, would you like to add anything?
I mean, I just, questions, like I think Mark started to address it, but questions like this there's a lot of different directions you can go, and I appreciated both Mark and Lucia's response. And again, if there's some specifics to that question, I would be happy to answer it. I think sometimes it's easier to really kind of understand exactly what's happening with the individual family situation to give a really kind of adequate answer to questions like that. So, I mean, I open my email up, and I'm also welcoming a phone call to the participant who asked that question.
Okay, well thank you so much. And I'm afraid we're running out of time. I would like to thank all of our presenters today for really struggling with and giving us some solutions to the problem of bridging service gaps. If we can go to the final slide, Claudia. The slides and the references are going to be posted for you at the Pathways RTC website that you see here tomorrow. And we have some specific questions that we're going to be passing on to the people who are on this panel from you as individuals. And so you may be getting an email answer to your questions. I'm sorry we couldn't take more of them this afternoon. Hope that you have a lovely summer, and thank you for your attendance.